This is Dr. Tawari.
And this is Dr. Kochak.
And you're listening to the Breast Podcast Ever. Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast. All right. Thanks for joining us again. This is Dr. Kochak.
Hey, Dr. Tawari.
We're sitting at home during this whole shutdown period and been keeping the practice alive. We've been talking to our patients over the phones and doing virtual consultations and keeping everything afloat. But as all of you know, the clinical operations still remain shut down. So it gives us some time to actually sit and chat and talk about some of the questions that are coming in. And one of the big ones right now, obviously, with the shutdown and the COVID running rampant, is all these reconstructions that are being put off. Is how are we going to address these delayed reconstructions and what are the options going to be? And so we thought we'd dedicate a little bit of time here today to talking about how we approach these delayed reconstructions that we're being dealt with right now.
Yeah, I think it's a good topic because we've heard from so many patients in our practice and other practices that have tissue expanders in place. And one question that's come up is, if you have a tissue expander in place, how long can you wait to get the DIEP flap? I think with elective surgeries being canceled, and as we've learned, DIEP flap sort of fits in that category. Is there a time frame that you can have the tissue expander in place before having a DIEP flap? So I'll kick that over to Dr. Kochak. What do you think, Dr. Kochak?
Yeah, I mean, the great thing about a tissue expander, and I'll kind of take it one step back and sort of reiterate that we are still able to be putting in tissue expanders in some cases, even in the current environment. So if a patient meets criteria to have breast cancer surgery, like a mastectomy, and there are criteria, we talked about them in our previous podcast. If the patient does have surgery, in some of those cases, we're still able to come in and put in a tissue expander. So a lot more patients are going to have these tissue expanders put in. And the good news is we've been doing this for a long time. It's a protocol called the delayed immediate protocol. So we would, what that means is it's a delayed DIEP flap reconstruction, but there's an immediate reconstruction that happens, and that's the tissue expander part.
You may have phased out there for a second. So delayed immediate protocol is what Dr. Kochak was saying.
Yeah, so this is a delayed immediate protocol. But back to what Dr. Tawari was saying is that once a tissue expander goes in there, that tissue expander can pretty much stay for an extended period of time. We don't like to leave them in much longer than a year, but technically speaking, they could be in there up to a year.
One question that came up this morning, Dr. Kochak, is what happens if your tissue expander is leaking? There's a lady from Arizona that had reached out to us about a leaking tissue expander.
I mean, that's a tough situation if the expander's been punctured, which can happen during the placement or during the fill process. It depends on how much it's going to be leaking. A lot of the times the leak is a very slow process, so we can usually address that with trying to just keep filling the expander. Obviously, the fix would be to go in and change the expander, but if we're able to plan the surgery not too far out from now, the autologous tissue DIEP flap operation, if it's in the next month or two, which is reasonable in this current environment, I think it's reasonable to think we can just keep filling the expander every time it starts to kind of deflate. I mean, its job is really to just hold as much of that skin and make it available for the final reconstruction. So I think if we're planning a DIEP flap reconstruction later on, I think it's reasonable to just keep filling that expander over and over again.
Yeah, I like the pillowcase pillow analogy, and I took this from Dr. Kochak, actually. The job of the tissue expander is to create the pillowcase. And we can then take out that pillow and replace it with another pillow. In this case, take out the tissue expander pillow and replace it with a DIEP flap pillow. So if the tissue expander is deflated and the pillowcase sort of heals away, contracts away, then that's not a great outcome. But actually, sometimes the tissue expander can be a little bit deflated and still maintain the pillowcase. So that's where it becomes a bit of a judgment call. Again, the more important principle here is we need the pillowcase. And so if that's being maintained, then the tissue expander, even a leaking tissue expander at some level, is doing something good for us.
And I think that's like why it's so important that this delayed immediate type of protocol, using a tissue expander in many cases up front and then coming back and putting the autologous tissue reconstruction later on. The advantage really is that the tissue expander really helps us sort of create a pocket for the flap. It helps create that pillowcase, the outer covering. And then it really just becomes a matter of unzipping that, opening it up, taking out the expander and stuffing that whole area with some volume. And in the case of a DIEP flap, that's skin and fat. And so it does certainly create a nice shape on the chest, and it helps us keep that skin that we would otherwise lose if we came back and did a reconstruction later. And I think sometimes you could even argue doing a delayed immediate, even just to avoid an immediate reconstruction, sometimes can be helpful, because it can really help define that otherwise very large mastectomy space. At the time of a mastectomy, sometimes that mastectomy pocket can be pretty big, sometimes bigger than the flap itself. And so if the flap's going to be a little smaller than the original breast was, I think it can also prove to be very useful in that setting.
So this is a little bit of a controversial thing. We've never talked about this, but do you think, Dr. Kochak, that you can get a better cosmetic result with a delayed immediate approach than you can with an immediate approach?
So we could, that's a great question. I think we could take a look at the literature, and, I think as far as I can remember just off the top of my head here, the literature would argue that it's potentially going to give us a better cosmetic outcome. Dr. Steve Kronowitz did a lot of work with that back at MD Anderson when we were training with him many years ago. And that work, I think there was some evidence that, especially in patients who went on to get radiation, that it could prove to be a beneficial thing, because otherwise, what was the alternative? We would have put a flap in and the patient would have gone to get radiation on the flap. And that can change the flap tissues, as we've seen, because we've done that so many times in our own practice. And so I would say that I think that there are some cases where it could certainly improve the cosmetic outcome. It's not going to necessarily always be the case. Yeah. I think there are some cases where I think the benefit is limited compared to sort of the risks of trying to get an expander to take. And, these patients have to heal and be able to get onto radiation or chemotherapy. So we have to weigh the risks of trying to get the tissue expander to take and heal well against those benefits. So I think we have to do it on a case-by-case basis. But I think most of the time, it could end up giving us an improved cosmetic outcome if it's serving the purposes that we outlined before.
Yeah, I agree with that. I think it's important to note that delayed immediate does mean two different surgeries. The first surgery is the tissue expander placement, usually at the time of the mastectomy, followed by eventually the DIEP flap reconstruction, versus an immediate reconstruction where the DIEP is done at the same time as the mastectomy. But I think the flip side of having two surgeries is oftentimes we can get the patient's final pathology. We know if they need chemotherapy. We know if they need radiation, like Dr. Kochak was saying. So there are definitely advantages to waiting.
Yeah, the original trial for the delayed immediate protocol was mainly in patients who had mid-stage cancers, where there was a question about this radiation. Would they need it or would they not? And the only way they ever really knew would be after the mastectomy, after the sentinel lymph node biopsies were done. And so it was actually in that specific group of patients, so that all of the information could be gathered, and then the plastic surgeons would have a very good idea of what types of adjuvant treatments, such as chemo, such as radiation, would be needed before doing the DIEP flap operation.
Yeah, so in some ways you figure out the cancer piece before you're dealing with the reconstruction, and that kind of just makes sense. But what do you think about the risk of having two different surgeries here, Dr. Kochak?
I think there's, it's not, while it's two separate operations, the tissue expander at the time of the original operation is a lot shorter. It's a shorter operation, and that's a combined procedure. You're having mastectomies and you've got the plastic surgery part. So it certainly makes the operation a little bit shorter for the patient, a shorter hospital stay on that front end. And then when we come back to do the DIEP flaps, now the mastectomies are done. So that's not added on to the time of the operation. It's actually less overall blood loss for the patient at that time. I do believe that the hospital stay is probably shorter in that setting because the patient that heals better, they get better quickly. And most of those patients in our practice go home the second day. I would say the people who end up staying a third day are usually the immediate cases. And if you look at the blood transfusions that they rarely happen, but if you look at the patients who do get a blood transfusion, it's usually patients who had an immediate reconstruction. And that's largely because there's a lot more surgery happening at a given time. So I think there's pros and cons to both sides of that argument, but I think they probably balance out.
Yeah, I agree with that. I think people have a lot of concern about the risk of anesthesia, a second anesthesia. And truth be told, the risk for anesthesia is vanishingly small. I mean, anesthesia is very, very safe. Of course, there are issues like postoperative nausea, as we've kind of gone towards a non-narcotic approach to our anesthetic care. We really haven't found that to be an issue post-operative nausea. I think the more we've gotten away from narcotics, both inpatient and outpatient for these surgeries, I think the less we've had to deal with post-operative nausea. I think the big value to a delayed immediate approach is the cancer's gone, and we can then sort of put that very serious concern aside and then really focus on the reconstruction, those aspects of the reconstruction. So for me, I think for many of the patients that I talk to, that's probably the biggest advantage, is the cancer piece has now been dealt with.
And I also think I totally agree. I think another really important thing to bring up here is, 10 years ago when we were doing this probably would not have been the same conversation, because we were putting tissue expanders under muscles or partially under muscles. And so the fact that they were going under muscles made the procedure a lot less favorable. I think it made it more painful. I think it made a higher seroma production. I think it was overall a less favorable procedure. But now, given the fact that it really is our usual practice, our customary practice, to put the tissue expander on top of the pec muscle, or what we call into the prepectoral plane, it really doesn't cause any change to the patient's anatomy. We're not doing a lot of internal surgery at the time of the mastectomy. We're really just, putting that tissue expander into a space that's already been created. And so it's less painful. I think they recover better. So because the procedure has changed, I think that's why now it makes a lot more sense to be doing these tissue expanders and following this delayed immediate protocol, not just in a time when we can't do a DIEP flap at the same time, but in cases where we might not know how much treatment's going to be needed after mid-stage cancers, in other cases where we think just aesthetically or cosmetically it might optimize the outcome. So I really think it's the nature of the procedure changing.
I think for a lot of patients that we use the delayed immediate approach on, they can't decide. There's so much that's being thrown at them at patients at the time of the cancer diagnosis that it's very, very overwhelming. And the delayed immediate approach, again, where we're putting a tissue expander in that prepectoral space, kind of leaves all options on the table. So patients don't have to decide.
That's such a great point. I mean, you're bringing up something so awesome, because that's one thing we have to address, right? So if you have a tissue expander, what are your options afterwards?
All the options that would have been true at the time of your initial diagnosis and our initial conversation, but we haven't taken anything off the table. We can still do a nice DIEP flap. We can still do a implant reconstruction in the appropriate patient, but it takes away that sort of time crunch of decision making. And I think for a lot of patients, it's nice to know that you haven't lost any options, but you don't have to decide and commit to something at the time when you're dealing with a cancer diagnosis.
Yeah, definitely. I think that's a great point. What other things kind of go along with this delayed immediate stuff?
I think the point that you made about the transition from the submuscular tissue expander to the prepectoral tissue expander makes a big, big difference here, not only because of pain for the patient, we're not manipulating the muscle. I think that whenever you have to operate on somebody's muscle, it's very unfavorable. It's the whole purpose of doing a DIEP flap, is to not take any muscle, not to injure or weaken the abdominal core, and the same is true with the chest. And I think because we're able to place a prepectoral tissue expander in place, we're able to do this in a rib-sparing fashion. It's really minimally injuring the muscle at the chest area. Also, I think we get more projection out of the ultimate reconstruction. Here we're putting the tissue expander and really kind of developing a nice pillowcase, not a pillowcase where we're fighting against the muscle. And I think ultimately when you put a DIEP flap in that same space, you get a lot more projection out of the ultimate reconstruction. I think that makes a big difference versus how we used to do it.
And I think maybe just to really kind of give our listeners sort of a clear idea of what this looks like, maybe you can kind of go through the whole process, like from the beginning to kind of finishing up. What does that look like? And we said it was a couple procedures.
Yeah.
Are there more? Are there less? What happens at each one?
Yeah, a lot of times, once the patient's been diagnosed and they've had a discussion with their breast cancer surgeon, we'll meet with them and we'll spend an hour going through all their options. We'll talk about tissue expander placement. We'll talk about DIEP flap, S-gap, DUG flap, whatever's appropriate for the patient. If we decide to proceed with a delayed immediate approach, well, then the first operation will be at the time of the mastectomy, where we'll place the tissue expanders, of course, place drains. And most people will be in the hospital overnight. Some will actually go home that same day. And over the first couple of weeks, we'll take out the drains and expand the tissue expander. And now we can fast forward maybe 3 months on average. 6 weeks to 3 months is when we're talking about doing the deep flap reconstruction. And that's
unless they have radiation, correct, or chemo.
Unless they have radiation or chemo, which changes this timeline by about 3 months. We'll take them back to the operating room and we'll remove the tissue expander, whether it's on one side or both sides, based on the mastectomy, do the deep flap reconstruction or the S-gap or the Doug flap reconstruction. And that typically is 2 to 3 days in the hospital with about a month-long recovery. And then a lot of our delayed immediate patients, in my experience, tend to be one and done after that deep flap operation. Because again, we've already established the pillowcase. So there's less revision to do.
And I think that sort of, speaks to the thing we were talking about earlier, does it make a difference? Well, it probably does, because so many of those patients don't need a phase 2 or revision operation after the deep flap, as opposed to those who had immediate reconstructions. I'd say it's almost always that there's going to be a second phase.
If there is a phase 2 revision, that's about 3 months after. So, of course, this is a long process. Reconstruction is always a long process. But I think that delayed immediate is a really important tool in our toolbox. And particularly as we're all dealing with the coronavirus crisis, I think it gives our patients an option for a good reconstruction while dealing with all the things that we are so concerned about in terms of PPE management and limiting exposure.
Well, I'd say that's pretty good, covering sort of the basics on this one. And I think we'll leave it open after this, and always encourage our listeners to reach out with any questions. We're always happy to answer them and respond. You can hit us up at our website. It's info@mwbreast.com. So stay tuned for our next one. We'll be making one very soon. So we look forward to putting it out very, very soon.
All right. Stay safe, everyone.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at mwbreast. Thanks for tuning in.
And join us next week.